Yes.
A very warm welcome from the Australian National University here in Canberra. I'd like to start by acknowledging the Ngunnawal and the Ngambri people who are the traditional owners of the land where ANU is located and where we are gathered today. And I pay my respects to the elders past, present, and emerging. We are delighted to welcome you to our first hybrid event for the LINK program on International Women's Day. Isn't it wonderful to be here in person and to have a live audience? A very warm welcome also to our online attendees who are joining us from various parts of Australia and the globe. The LINK program is the new name of the ANU COVID-19 peer support program that we started last year. And Link and Grow, one of its four limbs, is a global interprofessional program for women health professionals. As part of this limb, we are launching a blog /vlog to amplify the stories of diverse women in healthcare who played a crucial role during the pandemic. We are aiming to compile 100 stories, so quite ambitious. So if you have a story to tell, or if you know someone who does, we will email you the details, or you can Google the link ANU. Please feel free also to drop us an email on international.health@anu.edu.au. I am Dipti Talaulikar, clinical hematologist and the program lead for the link. My team of volunteers and I have worked hard to put together this panel discussion today on women in healthcare, breaking the bias. And we're focusing on culturally diverse women as a particularly vulnerable group. Joining me today on the panel are Anna Olsen, Associate Professor of Social Foundations of Medicine at the ANU Medical School, Marrwah Ahmadzai, Obstetrics Registrar at the Canberra Health Services, Dr. Sandra Krishnan, General Surgeon and Breast Surgical Oncologist who works at the SAN in Sydney and is affiliated with the ANU Medical School, and Associate Professor Sanjaya Senanayake, an ID expert who has become a household name during the pandemic. I should say at the outset that our panel has been drawn entirely from our fledgling team at Link and Grow within the ANU Medical School. And that while we are very proud of those who are here, we are also aware of those who are not at the table, which really reflects the systemic issue of lack of diversity in healthcare. A couple of housekeeping notes before we start. All webinar attendees have their video and microphones switched off. This just helps to keep the sound quality clear and reduce interference. Unfortunately, we will not be able to entertain questions from webinar attendees, but I encourage everyone to post questions and comments. We will read them, we will learn from them, and if possible, we'll try and address them in some way after the panel. You can post questions anonymously if you wish to do so. There might be a poll that pops up later during the discussion, and if it does, please do select your preferred response and be assured that all responses will remain anonymous. And finally, please note that this forum is being live streamed on multiple platforms and is also being recorded. So with that, we might kick off. So my first question is to Anna. Anna, I appreciate you're our only white person on the panel. Thank you for joining us today to discuss the challenges faced by women of diverse backgrounds. Perhaps we can start by taking a step back and talking about problems faced by women in general and women in healthcare in particular, because that does remain an ongoing issue.
Thank you, Dipti, and thank you for inviting me. I am here as an ally. I'm here as someone who doesn't work in the medical field, but is a researcher who, in my career, has focused on gender, in particular working with different minority groups. So I hope that perspective as an ally is something that's useful and interesting in this panel. In terms of gender and where we're at in terms of thinking about women and the workplace, things have changed dramatically. I was a child in the 70s, and I was born in the 70s, and I was a child in the 80s and 90s, and it was at that time that feminism was at a very particular point in time. It was very much about equity. So it was about empowering women, and that women can be and should be equal to men. And indeed, my mother's first job was as a female scientist on a women's wage. So it wasn't that long ago that even wage equity and that very, what we think are quite shocking, was an issue for us in our Australian workforce. So fast forward today, and we're still talking about gender and women in the workforce, but it is in a different way. The way we talk about gender, the way we talk about women has changed. There's a lot of terminology which has changed. Today, we've got International Women's Day, and it's a focus on bias. So we're focusing on bias. And that's a term that we didn't think about 20 or 30 years ago. That is something that there's so much research about now to show that all of us have these unacknowledged implicit biases within us. And this affects how we interact with each other in the workforce. And there's lots of research to show that it's what often limits women in the workforce. So the way that women are perceived of, talked about, given pathways to leadership or not, are often no longer as obvious as an unequal wage. They are much more silent and implicit. So that is why we're still talking about it today. Great strides have been made, but there is still inequity that exists.
And other panel members, please do pipe in. We want to make it as robust and interactive as possible. So, Anna, can I ask you, I recall you saying that you were supervising a PhD student who's doing a project on sexism in medicine, and in particular, if I remember correctly, surgery. Obstetrics, there you go.
Yeah.
Can you give us a little bit of background? Why is this research required? And if you have any preliminary results and can share them with us, that would be
wonderful. Thank you for that, Dipti. Yes, I've got a fantastic PhD student at the moment who is a clinician and has come to us at the med school to do her PhD in using qualitative research. And she's been interviewing specialists in obstetrics and gynecology around gender and women in the workforce. So really, I'm picking this rich tapestry of experiences that we have in the modern world and in modern medicine to try and think about what it's like to work as a woman in a particular field. She has some really amazing data from mostly women, but also men of all different sorts of age ranges, which really highlight the complexities of being a woman, and in particular being a woman who can or wants to childbear in the modern workforce. So a lot of what we talk about nowadays in terms of, for example, income inequity, there is still income inequity in medicine. So still generally, and even in nursing, all fields, men tend to earn more than women, but it's not about necessarily about the unequal wage, it is the burden of caring. So a lot of what Mel's PhD is looking at is how the burden of caring for the next generation impacts on women's careers in a way that's both implicit and explicit, and, for example, has some very appalling data on what it means to sometimes go for roles in medicine as a young woman and being asked questions like, what is your plan for family in the future? Which is actually illegal to ask people about their personal plans, but it still happens in today where women are sometimes in job interviews asked about whether they would be having children. So this concept of inequity seeps through lots of different parts of medicine and the women's workforce in general.
I've heard that being described as the maternal wall. So not only is it income disparity that it leads to, but there's also the question, it draws into question the woman's commitment and her competence during those childbearing years as well.
That's very true. You tend to hide the fact that you have children. It's like, no, not me. I don't have any children. I have two, but secretly.
Yeah, absolutely. And there's lots written about it, and the way we're talking about it has changed quite a lot, and I think in a really productive way. And it's about acknowledging difference, and that child caring is something that's important and is a point of gender difference, and that it falls on women, that actually caring is something that should be something that's important to the society as a whole, not just to women.
And actually, if your thoughts just evoked a memory for me, a surgeon a very long time ago, a female surgeon who was a pioneer in her field at the time. She had a female protege registrar and had high hopes for her. That registrar got pregnant, and that registrar told a friend of hers how that surgeon just told her off and said, "You ruined your career." And I mean, that was a long time ago, and hopefully attitudes are different now, but that is that maternal wall that you talk about. And it shouldn't have to be that way.
It should.
Yeah.
Unfortunately, Melanie's work is showing that it hasn't as changed as much as we'd hoped, Sanjaya.
Really.
Well, I think it's not as overt as it used to be, but now it's unconscious and sort of silent, like you mentioned. So the bias is just behind the scenes. No one would come out right and say something like that because you get shot, but you'd certainly behave in a way. Someone might behave in a way that,
Thank you, Anna. So Marrwah, thank you for taking time off your busy rotation in obstetrics, and welcome to the panel.
Thank you.
Can I start by asking you to tell us a little bit about yourself, about your journey in medical school and training, and perhaps even before that?
Sure. So I was born here in Canberra to Afghan migrant parents, and I studied medicine at the University of New South Wales. This is an undergraduate degree. And I've also studied a master's in public health. I am currently a trainee in obstetrics in my first year. And I'm also I'm interested in this space for a couple of reasons. First of all, from my own experiences and interests outside of medicine. So I'm quite a vocal advocate for diversity and inclusion. I've spoken about this topic in a variety of platforms, including on the TEDx stage. And it's something that I frequently talk about. But also, I guess, going back to my own experiences in medicine as a junior doctor, I think many junior doctors face a lot of barriers in their training in general, regardless of who you are. And it's well documented. There's high rates of workplace stress. People have very stressful jobs as clinicians. It is a very busy lifestyle, and it's hard to balance all aspects of your lifestyle. And so there's also significant mental health impacts from that. And many junior doctors struggle with things like bullying and harassment in the workplace that they don't speak up about in general. And then I think when you look at the intersection of things like gender, race, and religion on top of that, there's a lot of issues that come up for clinicians like myself. There's been, I think, in my own experience, I haven't had challenges in sort of career progression being who I am, but I certainly have experienced comments both by patients and other clinicians regarding perhaps my appearance or whatever presumptions that might carry. So one example that I remember from my very early days as a junior doctor is when I went in to see a patient, and I was talking to them about their discharge plan, and they cut me off and said, "You actually a doctor?" And I said, "Yes." And they said, "Oh, I didn't think your foreign qualifications would measure up here." And I think, although that's something that not everyone as a clinician might be able to relate to, that certainly also have had many experiences that other female healthcare professionals would relate to. So for example, many of us might have been in this situation where you walk into a room with a male colleague, whether it be a more junior colleague or a medical student, and introduce yourself as the doctor and have a conversation with someone, but they address their questions to the medical student because they assume that they must be the doctor in the room or the more senior person. So I think these are some of the things these are some of the reasons why I'm very interested in this topic.
Thank you for sharing that with us, Marrwah. So what advice would you give to someone who faces similar situations? How did you deal with it?
It's very difficult. I think in particular when medicine still is very hierarchical and things are changing, but the reality is that there is still a hierarchy in medicine. So I think a lot of junior doctors who are in this position feel that they shouldn't say something because it might affect their career progression. But the reality is that that's not the case. I remember another experience where I witnessed a fellow colleague who was female of Asian heritage who had an experience like this. And she went in to see a patient and the patient refused to speak to her and said, "I'd like to speak to an Australian doctor, please." And she was extremely distraught by the interaction, but didn't want to say anything because she didn't want to be seen as rocking the boat. And she just said, "Oh no, it's okay. Like, I won't make a big deal of it. It's fine. Maybe next time we need to go talk to the patient, we'll find someone else to go speak to them." And I said, actually, it's not okay. You need to say something about it. And I think it's important that we foster that culture. And actually workplaces are very receptive to things like this and do want to see that everybody's treated equally and welcomed in the workplace. And there are lots of formal strategies that people can address these things. So speaking to someone you trust in the workplace for advice is a really good thing. Escalating to your supervisor, immediate supervisor, or senior registrar, or whoever it might be that you're working below that might be able to help that you trust. And there are also formal processes for reporting things like incident reporting, such as in Canberra, the Riskman system. So these things should not be tolerated and aren't tolerated. And if we report them, the more we report these things that happen, the more we can address them. And I think also in the moment when you're speaking to someone and you might encounter something like this, there are ways to go about it in a respectful and professional way and remove yourself. So I've been in this interaction which I felt was, I was talking to someone again for a purely medical reason, but the conversation immediately changed and became racial. And so I tried to remove myself from the situation. And I said, look, I'm here to talk to you about your cast, and I'm just going to pop out and grab the material we need to set up the cast. And when I come back, I'd appreciate it if we don't talk about this further. And I think that helped in that situation, but it's difficult to do because it can be very distressing.
Well, did your Asian medical colleague, did she come to some resolution?
Yeah, so she notified the team and then it was escalated to the consultant, and the hospital did take action and speak to the patient.
Because as a consultant, Sandra probably agrees as well, I would take it upon me as my responsibility to look after someone on my team.
Yeah.
But it is challenging. You don't want to upset the patient, but at the same time you have to address that issue because you need to look after your staff and see them valued as appropriate.
Yeah.
And Sandra, have you
I think yes, and I think that part about the staff member, the healthcare worker being valued, I think that debrief from someone up top is really more important because you can talk to one patient and you can talk to 100, but then the next one walking in the door. And Dipti and I were discussing a little bit about this sort of unconscious or conscious bias. No one comes in with a sign that, I'm not going to like anyone unless they look like me or talk like me. So they don't have that sign. So I think empowering the person going through it, that's really important.
And I think that also highlights the importance of having diversity, whether it be gender or race, in leadership positions in hospitals.
Yes, yes.
Patients in hospitals see lots of brown female specialists running around. They won't give it a second thought to engage with a more junior person who's like that.
Yes.
So that's a great segue actually to my next question. What do you see as the benefits of diversity, especially in healthcare? Why should we work so hard to make sure that we have that representation? How does it matter to patients?
I think it's a fantastic question, and I think diversity in healthcare is so much more than lip service. There's a huge body of evidence that diversity is beneficial, and a lot of it actually initially came from the business world. There was a lot of good research in business that more diverse teams are more efficient. They have greater financial gains than non-diverse teams, etc. And now there's a lot more interest in medicine in the same topic, and there's been a lot more research into it. I think as a clinician, seeing diversity in the workplace, I work in a very diverse workplace, and I see the benefits for our patients. And it's well documented that, as an example, patients from migrant and refugee backgrounds tend to have poorer health outcomes in general. And on the flip side of that, patients who are cared for by people from similar backgrounds or who might speak the same language as them generally tend to have better outcomes. There is a lot of research about this from across the world. But it's not just for patient outcomes, although we all have a moral obligation, in that perspective, but also people who train in more diverse institutions. So our students and our junior doctors who train in diverse institutions are more likely to be more well informed of things like culture, gender, race, religion, and therefore be more empathetic, more sensitive clinicians. And finally, if we have more diversity in the healthcare research space, then those underrepresented or minority communities that we don't have enough research about, and therefore, their healthcare outcomes are affected by lack of data, they will be more represented in healthcare research and will be able to better serve them.
I think there's also the question of social justice. It is the right thing to do to have that representation in medicine across the board. Thank you for sharing your journey with us.
Thank you. Thanks for having me.
Our next panel member, I hope you don't mind my saying this, Sandra, but you're a rare breed, a culturally diverse female surgeon. Thank you for joining us today. We are delighted to have you here. As someone who is further along the path in medicine, can you perhaps talk about and add to what Marrwah has said? As a culturally diverse woman, mid-career woman, what struggles and barriers have you faced, and how have you worked to overcome them?
Thanks, Dipti. I must congratulate you and the team for this. So a real pleasure to be here. And I have been thinking, especially last night, about my list of experiences. There's so many, it wasn't hard to look at them all and pick a few. So I picked a few words that were said to me over the years. One from my son, pre-fellowship, one from one of my bosses, post-fellowship, and one from a patient. So I was operating on a Thursday and I went home at night. This is before the exams. And my son said, Mom, you missed my mathematics day at school. So I said, oh, Zach, I just need notice. And he said, that's okay, Mom, your patients are more important than my math. And that really hit home. And that's not just as a culturally diverse woman, it's just as a parent, any parent. Surgical training can be quite horrendous. And that's a forum for another day. So, but that's just one aspect, one question. the one from my boss was on passing my fellowship exams. 12 years ago, I rang him up and I said, I passed. Oh, I never thought you'd do it. So that was hurtful. It was hurtful because unlike you, Marrwah, if a patient says to me, you didn't do your medicine here, or you didn't, how is your qualification equivalent? I wouldn't be able to answer like you. I would have to say, yes, I did do my medicine somewhere else. And I wouldn't be able to fall back on that UNSW, that you had. So it's a bit different for me. So it did hurt a lot because I worked very, very, very hard to sit the fellowship simply because I didn't want to be any inferior. I wanted to be on par for the patient, for myself, for my peers. Anyway, my third thing is the patient. So we moved to Bega, the far south coast, to start a life there. And my practice manager rings me one day and says, she was trying to book a patient in, and the patient says, what does one do to get an Anglo-Saxon doctor around here? She was taken aback, and she told me about it. And I was, of course, again, hurt. I mean, those days I used to get hurt a bit more than these days. I've become a bit stronger. I've become the wall, I think. But so that took time to adjust and to understand. I mean, our whole lives, and I put this on my Facebook post the other day, we all need and want belonging to a pack, a group, a corps, a team. And that's precisely the source of bias, because anyone outside of that is, we're hesitant to trust. And it took me time to understand, Sandra, you are not going to blend in. Nothing you do is going to make you whiter. Whether the way you look, speak, think, act, and it took me years to process that my actual superpower was in just being exactly what I am without apology. And once I figured that out, I fell in love with the community. The community fell in love with me. So we have a really happy ending. For those of you who are interested, my practice manager told that patient, one travels around the Brown Mountain and pays $300, and one can get It's beautiful to, and what you said, Anna, about being an ally, I don't know about other culturally diverse people, men, women, but we sort of have a radar. I sort of have a radar on who's, an ally, especially when they, come to you when you're feeling down, or when you've had a bad day and they come up to you and you know that, hey, this is a friendly person. This is someone I can talk to. You can't talk to everybody. So it's nice that at Bega and at that hospital, and later on here in Canberra, there were so many allies around that you belong despite your background. So snapshot of my struggles.
Sandra, that resonated so much with me. I again I'm overseas trained. So saying that your diversity is actually your superpower is amazing. You have to own it. You can't hide from it.
Yes.
There's no way you can hide the color of your skin.
Yes.
You have to own it. There's no way you can hide your headscarf. You have to own it. It's part of who you are.
Yeah.
I think also finding allies and really trusting your gut, knowing that if you face resistance, it's not imagined, it's probably true. So you analyze it carefully, but then you trust your gut and navigate around resistance, find allies and move forward. It's no one's place to say no to you. You have the right to do what take the path that you want to, within reason, of course.
Yes, yes.
But you do have that right as much as anyone else. So it's just recognizing that and owning that becomes so important.
And I think people like Sandra in the medical field, you're providing or leading the pathway and the trajectory for a more diverse workplace. There's a comedian whose name I've forgotten. He was saying, if you ever are feeling sick and you collapse and go unconscious and you wake up in a hospital surrounded by white doctors and nurses, you know you're on the TV set of Home and Away or Neighbours. Because it's not like that if you go to any hospital around Australia, because it is very diverse in terms of women and culturally, race as well, which I think is a great thing. That will, and people like you and Marrwah will help us.
Sandra, thank you for sharing your story. I hope it inspires many, many women and culturally diverse women to take up surgery. Thank you for being an inspiration.
Thank you.
Sanjaya, thank you for being a token male on the panel.
Well, as far as you know.
Very diverse.
Please tell us a little bit about yourself and any insights you might have on challenges faced by diverse women, both at work and on a social front.
So Dipti, thank you for inviting me. It is a real honor to be the token male on the panel, actually. So for International Women's Day. Look, actually, before talking about myself, I just wanted to talk about Dr. James Barry, who was a physician. James Barry qualified from Edinburgh in 1812 and served in the military, I think, and sort of died in 1865 and got the highest accolade, the Inspector General of the hospitals in the British Army. But it was only after his death in 1865 they discovered that he was a she. He was Miranda Barry. And Miranda was one of a few females who had to masquerade as a male back then to practice medicine, because women weren't allowed to practice medicine. They weren't allowed into medical schools until the late 19th century. So generally there'd been doctors for hundreds of years, but they'd always been men. Women could only be the sort of healers. And that, of course, went into put them into conflict with the church. So you had witches and witch burnings, etc. So it was pretty rough for women. And midwives were initially women, and it was dominated by women. But then when the forceps came out, and you probably know the history of all this now, but when the forceps came out, the male surgeons suddenly took over because it was a procedure. And they started pushing away women from midwifery. So I think, and also I'm going to read this quote from Dr. E.H. Clarke from a book that was published in the 19th century. Now I'm assuming E.H. Clarke is a man, which warned that higher education in women produces monstrous brains and puny bodies, abnormally active cerebration, and abnormally weak digestion, flowing thought, and constipated bowels. Now, we haven't conducted.
That's the reason for that.
Look, we haven't conducted any randomized controlled trials, but none of the female doctors I've worked with have been farting excessively on ward rounds or burping to support that theory. But it just shows you what level of discrimination women have to put up with. Now, it certainly hasn't been resolved as yet, but we're certainly in a better place than where we were. I was reading another article from The Lancet where they cited Christine Lagarde, the International Monetary Fund chairman, who was saying in 2018 that the male domination of the banking industry had made the global financial crisis more severe. If it had been Lehman Sisters instead of Lehman Brothers, we would have been much better off today. But even as Marrwah talked about in medicine as well, there's studies showing that female patients with acute myocardial infarction, so heart attacks, are more likely to have a better outcome if they're treated by a female doctor. or a male doctor who has lots of female colleagues. So there are definitely advantages to having women being in the medical workplace, for sure. And I think, Dipti, you did ask me to talk about sort of where we are at the moment. And in terms of gender equity, the World Health Organization looked at about 104 countries and looked at their medical workforce systems. And they found that women formed about 70% of workers in that area. So that's not just doctors, but nurses, allied health, dentists, etc. And that representation has been increasing since 2000, which is good. But women are still less likely to be in full-time employment, and we do see that here as well. So a lot of part-time employment for, that maternal wall you talked about, Anna. So that would account for a lot of that, and that there's a gender gap of around 28% in the health workforce. Not Australia as such, but in all these countries around the world. In Australia, the Australian Institute of Health and Welfare, they publish Australia's health every couple of years. The 2018 one showed that 16% of the employed medical specialists in Australia in 1997 were women. It's up to 31% in 2016. And all the colleges, so emergency medicine, physicians, surgeons, they all have gender or diversity equality working groups, and they are actively pushing to improve numbers of women working in those areas, which is great, but I think they've all still got quite a way to go. In terms of gaps, only about 30% of deans and chief medical officers or medical boards or university heads are women. So there's room to move. And as I said, if you have those people in those leadership positions, it's more likely to inspire others to come through.
Sanjaya, it's exactly the opposite for white males. I read, if you look at entry-level positions, about 30% of the positions are occupied by white men, whereas once you move into the more senior positions, it's almost 68%. So that is the one group of people who actually tend to break the glass ceiling and sit there very comfortably.
It's interesting, because there's lots of metaphors that come along with trying to explore and explain and pull apart gender in the workplace. And it used to be the leaky pipeline, and so this was the idea that there's a pipeline to the top, and women kind of leak out for various reasons, because there's not enough of them, because they choose child caring over profession and all that sort of stuff. And that's kind of largely been put aside because it was deemed to be a metaphor that was that didn't problematize the workforce enough, that was kind of suggesting that women were making choices to not make it to the top. So that's kind of been put aside. And one of the newest ones is now the sticky floor. So that's a really interesting, that sticky floor, and the fact that you've got majority of women in the lower level of the workforce, and the men at the top of that sticky floor. So that metaphor is one that works well for me, and it's that difficulty of rising up, not necessarily because of choices, but because of opportunities that are given to you. Mentoring, which I know is something you're really passionate about, just those opportunities are still less available for women, and even less so if you're a woman in a minority group.
Thank you.
There are other forms of discrimination as well. I was reading again the Lancet that gastroenterologists and proceduralists who do endoscopies, there's very little engagement with industry. So these machines you're using to do procedures, they're not made small enough for women who've got smaller hands. So they're more likely to get long-term injuries as well. So I mean, that's another way that diversity is not being addressed in the workplace. So I think there are lots of things we can do to make things better.
So I think, Sanjaya, we talked a lot, especially with Marrwah and Sandra, about what women can do to break barriers in flawed systems. Can you perhaps tell us a little bit about what people can do, what individuals can do, what men can do, and what organizations, which are still led by men overwhelmingly, can do to support women, particularly culturally diverse women?
I think attitude is the first thing. I've been very lucky in medicine since I was thinking I've almost been a doctor for 30 years, so quite a long time. And in that time, I've been lucky enough to go, I guess, through a physician pathway where women have always been prominent. So even as an intern, as a registrar, I had female consultants. And we, in our field of infectious disease, we never think about them as women. They're just my infectious disease colleague. And that was then as an intern. And even now as a consultant, I work with 3 infectious diseases consultants who are women, and I don't ever think of them as women. I just think of them as, that's the expert in antimicrobial stewardship. I can ask a question about, or my microbiology colleague, she knows the answer for this. So I think that's really important. Once we just don't even think about ourselves as men and women, we just think about ourselves as doctors, then I think that changes. Having said that, there is the reality as well that women are still take on more of the caring role in the family than males, and we just have to be able to accommodate that without a second thought. And certainly we've had trainees who've announced that they've been pregnant, and that's fine, and they get their leave and they come back, and we don't make a fuss about it, and we look forward to their return. So I think that attitude also has to change. And any I guess systemic attitudes need to be weeded out, and that has to happen from the very top. And again, it helps in our health service as well at Canberra Hospital. We've got a number of women in senior positions as well. So I think all that helps.
Thank you, Sanjay. So we've gone a little bit over time, but I'm just going to continue. To all the 3 awesome women here, what can women do to support each other, to be allies? Because I think I have this written down somewhere. They call it the tug of war. Bias against a group, which in this case is women, actually fuels conflict within the group. Anna had another term for it, so I'll let her address it.
Yeah. I mean, again, there's quite a few sort of terms and metaphors that we use to talk about the issues of minority groups and what happens when there's power struggles within minority groups, going for leadership roles. And I think it's certainly something that hasn't gone away, and it's something that's incredibly complex. And from my point of view, as someone who works as a social scientist in health, what I'm most interested in is not only that the individual pathways that we can take, choices that we can take, that the work that we can do within ourselves to address those biases that we all have, but it's also what we can do at a system level. Because the reality is a lot of the power struggles, a lot of the biases that we have are baked into the system. They don't allow, they're structures that up until very recently haven't allowed people to take leave. So in terms of obs and gynae, you can't take leave during some of your key training years. So it's not possible to do it part-time. It's not possible to start it and take leave and come back. So there's lots of structural issues baked into medicine, which make it incredibly difficult for all people, but particularly for women in caring roles to progress.
I think the other thing I'd like to highlight is sort of unlearning what we know about success and opportunity. So there are certain groups of people, women, culturally diverse women, those with disability, those who the various sort of groups that are there within these backgrounds that have to work so much harder to get to the same place because of the barriers that are put in front of them. And so I think allyship is very important for men and women of across the board to correct that imbalance in success and opportunity, and give each other a pat on the back, give each other a leg up.
I think
Dipti, oh, sorry.
No,
you go.
no.
You go.
You go.
Oh, this
Well,
is a conflict.
conflict.
In the group.
Well, I wanted to say that we can make all the policies and the guidelines and the systems in place, and they are very helpful, those external barriers. But at the end of the day, bias is a very personal thing. And I remember my daughter's psychology textbook had a paragraph on bias, and she taught it to me. The way to overcome your bias against this particular group is to find one person in that group and go for a one-on-one chat, get to know them as a human being. And then that bias will disintegrate because now you know that group. And this whole thing just brings to mind the Hidden Figures movie where Kevin Costner, I don't know if you watched it, but he literally breaks down the sign on the toilet wall because of his emotion. And he's wanting to just get the job done. I don't care who's doing it. Let the lady go to the loo and get the job done. And we need more Kevin Costners or people with that sort of human emotion and on a personal level, So I have two ways that I deal with it, and then I'll let you go, Marrwah. One is I want to be the best that I can be and live the best life that I can live. Not just for myself, but so that I can show that, look, it's possible. If Sandra can do it, you can do it, to my students out there. The second thing I'd just like to stress on is on the way there, you reach out and help as many people as you can, as far as your arm can reach. You don't have to be dean to help a medical student or somewhere, a registrar. You don't have to be head of department. Everyone's a leader.
Leader without a title.
A leader without a title. And we may not get the title because that's a huge topic. But on my way, I will pluck out and pull out as many people as I can. And then together we make that journey.
I read something about that, Sandra, where they say if you draw up a seat at the table when you weren't there before, so you struggled to get there and draw up a seat. It's not just about sitting at the table, but making sure you pull more seats up beside you.
Yes.
I think that's what that goes back to. And I was just going to add to what Sanjaya and Anna mentioned about, I guess, organizations and what we can do. I think, as Anna mentioned, I think a lot of it is a lot of systemic issues. So even as individuals, if we do our best, there's still a lot of systemic barriers. And I think there is a lot that organizations can do and are doing. So not just, I think there's a lot of recruitment in diversity at the moment with a lot of explicit terminology on recruitment websites that is really good. It's really encouraging and welcoming. But it has to go beyond just recruitment and make sure that we retain people from diverse backgrounds. And in order to do that, we not only have to make them feel welcome as best as possible, but listen to their needs. So I think it's sometimes hard to do that in a healthcare space. Everyone's very busy and pursuing a clinical role, but things like putting out surveys to staff so that they can express if they're satisfied or if they've got particular needs that aren't being met, they can anonymously log those things, or focus groups with people who, certain people within your organization that you want to hear from or want to serve better. I think those are some practical steps.
There's a very interesting quote from Plato who says that there is nothing more unfair than the equal treatment of unequals.
Oh, ouch.
Thank you to our wonderful panel and to all the attendees, both live and online, for this wonderful discussion. I have one more thank you before I close the session. The Australian National University and DIMIX from Canberra Centre have sponsored book vouchers for our event today. So Barbara is going to run a lucky draw and post out gift cards with a carefully curated list of 7 books on diversity and inclusion. Whoever gets the voucher or the gift card can go and purchase those books from their local store. One of the worst comments I have had from a colleague, and I'm sure it was kindly meant, when I expressed my academic aspirations was, look around you. Do you see anyone with your profile in academics in Australia? And sadly, while things are changing, there still aren't many people with my profile or with the profile of a number of other minority groups out there. And so while our institutions slowly, sometimes creakingly make those changes, it's always hard for big organizations to make those changes. It is up to us as individuals to break barriers, one barrier at a time, to change the landscape and make space for the Marrwahs of the world to do what they were born to do and to take the rightful place in the world. I'll end there. Thank you for joining us today.